Good afternoon. My name is Erin Marshall, and I'm with Constellation Consulting. We are pleased to present the New Mexico 2021 Summit on Health Equity. The summit is funded by the New Mexico Department of Health Tobacco Use Prevention and Control Program, and will take place throughout May on our event app with live sessions every Wednesday afternoon. And for more information about the summit, you can visit our website at nmhealthequity.org. Due to the COVID-19 pandemic, this year's Summit on Health Equity remains an online event, and we appreciate those who have participated and supported this year's event, including the New Mexico Department of Health, our Summit Planning team, you can see their names here, and Presbyterian Healthcare Services, Con Alma Health Foundation, Be Well New Mexico, Santa Fe Community Foundation, and many others. And for a full list of our supporters and our online exhibitors, please visit our event dashboard online or on the Whova app. And so I also encourage all of you to utilize this year's Summit on Health Equity event app. The Whova app provides you with all of the opportunities to network online, to schedule the COVID-safe meetups, create discussion groups, visit our exhibitors and our supporters, watch recordings of sessions that you may have missed, or if you want to review them, download files provided by our presenters, and much more. It's a great tool, and we encourage you to use it not only during our live sessions, but also throughout the month of May. Plus, when you use the app, you can earn points, which means prizes, and you can check the leaderboard in Whova for more information. So for today, attendees, webcams and microphones have been disabled. If you have a question for the presenter today, please use the Q&A function within the Whova app, and we will address as many questions as time allows during the Q&A session at the end. Also, any materials provided by today's presenter will be posted as part of this session within the event app. Following today's session, we appreciate if you will take a few moments to complete our session feedback by clicking the rate in the session of the Whova app. And if you would like to request community health worker or social worker CEUs or continuing medical education credits, please include your name and email address on the evaluation, and CEU certificates will be emailed out within 60 days. If you need any assistance on the CEU, please email us at info@constellationnm.com. If you need assistance during this session, please use the Q&A feature on the Whova app or the Ask Organizers feature in the Whova app. You may also try emailing us directly at info@constellationnm.com. Finally, we begin today. Constellation Consulting wants to acknowledge that our organization operates primarily on the unceded ancestral homelands of the Tiwa-speaking peoples. Racism has no place in our communities. Constellation Consulting and our team members are committed to racial equity. We acknowledge and denounce the violence and discrimination affecting the Black and Asian Pacific Islander communities with whom we stand in solidarity. We are New Mexico, and we were built strong by the diverse people of our communities. There are a variety of organizations supporting health equity throughout our state, and we've listed a few here, but encourage you to seek out, learn more, and become involved with and support organizations who are building a better New Mexico for us all. So today, for this session, we are excited to host Captain Will Darwin. Captain Darwin is a commissioned officer in the United States Public Health Service and has been with the Indian Health Service since 1997. Dr. Darwin completed his Doctor of Pharmacy at the University of New Mexico Health Science Center School of Pharmacy. And he is currently stationed at the Albuquerque IHS Regional Health Office and is tasked with the dual role as the area pharmacy consultant and the area clinical application informatist for the region. And I'm sure he could say that easier than I can. You could read about all of our presenters in this series. You have their complete bios are on the event app at Whova and also on our website at nmhealthequity.org. So please welcome Captain Will Darwin.
Thank you very much. I'm just doing a quick audio check. Just want to make sure that you all can hear me. All right, go ahead.
You sound fine, Captain.
All right, thank you. Let me just adjust my screens here and we'll get going here. Again, welcome and thank you for the opportunity to let me to elaborate about our healthcare system here. So we are a system. So the point that I'm going to be bringing up on is the Indian healthcare system, on how equity, prioritization, COVID-19, the pandemic evolved within our healthcare system. So again, welcome to this session here. So the objective of our session is to formulate concepts surrounding health disparities and health equity in American Indians, Alaska Native during the coronavirus pandemic. 2, to provide a high-level understanding of the various technical aspects related to COVID-19 vaccines. 3, no vaccine acceptance and hesitancies in Native American communities. 4, to understand vaccine dose allocation and cadence planning and execution in the Albuquerque area Indian healthcare system. So we'll go ahead and kind of lead off with the roadmap here. So we're going to just look at this as our roadmap throughout the presentation here. So we're going to look at public health recommendations, and we're going to go technical with some vaccines. We'll talk about variants, and then we'll go to social determinants, such as vaccine hesitancy. Then we're going to go into dosing allocation and cadence. We'll talk about the priority phase groups. And as we lead into the latter part of the presentation, we'll talk about data management and then some of our successes and lessons learned that we are still continuing to deal with this pandemic here. So this is a timely slide here, very poignant, also very interesting on how we evolved to this day and age here. These are just news flash, news bulletin throughout the past few decades. And I'm sure you're familiar with some of these news flashes here. You know, a few years ago with Zika, MERS, Ebola, obviously the hantavirus in the greater Southwest, SARS, and obviously right now the coronavirus 19 here. So very interesting times, interesting days, interesting community efforts related to communicable infectious disease preventions and mitigation processes here. So I think we have a lot to learn and gain from as we go forth in the upcoming future events that may be coming upon us here. So just lots of lessons learned that we can learn from. So from an Indian Health Service Agency goals here. So as of March 31st, 1 million vaccine doses were administered. So these are our main goals as of 2021 here. 45% will be fully vaccinated, 60% will receive at least 1 dose. So we do, as an agency, have not weekly, but monthly goals that we try to attain here. So far we've been meeting most of these metrics here as we go month to month here. So this is for the month of May here. So just some definitions about why we're all here today here. So we'll go through some 3 definitions here. Health inequities, differences in health statuses or in the distribution of health determinants between different population groups. Health equity, when all people have the opportunity to attain their full health potential and no one is at a disadvantage from achieving this potential because of their social position or other social determined circumstances. And lastly, health disparities. What does health disparities mean? It's a type of difference in health that is closely linked with social or economic disadvantage. Health disparities negatively affect groups of people who have systemically experienced greater social or economic obstacles to health. These obstacles stem from characteristics historically linked to discrimination or exclusion such as race or ethnicity, religion, socioeconomic status, gender, mental health status, sexual orientation, or geographic or location. Other characteristics can include cognitive, sensory, or physical disability differences in health along social, economic, and racial or ethnic lines here. So the next slide is we're going to put this all together into one graphic here. So looking at this graphic here, I found this tool online here in one of the leading health equity discussion board here, but this just kind of brings it, I think, into one simplistic way of trying to understand what we just elaborated with the definitions here. So going from left to right, you can see equality. You can see that the 3 participants are at an event at different levels. They're trying to watch an activity. Now look at equity there. All 3 participants are able to see the activity. And you can see there's some line of separations between equity and equality. Now look at reality here. So this is how reality looks like from different points of view or optics that we see how health equity is looked at here. But if we take down the barriers, notice that I labeled this no disparities. The fencing is not there. All 3 participants are able to see the activity within their own elements there. So I think this is what we're trying to achieve with health equity within the healthcare force. So let's go into some facts about health disparities and health inequities. American Indian Alaska Native have a life expectancy that is 5.5 years less than the United States all races population. American Indian Alaska Native continue to die at a higher rate than other Americans in many categories of preventable illness, including chronic liver disease and cirrhosis, diabetes, and chronic lower respiratory diseases. In July of 2003, the United States Commission on Civil Rights published a report that outlines civil rights disparities in healthcare for Native Americans. Unfortunately, most of the findings that was published back in 2003 are still same and very similar and true as of today, 18 years later. So let's talk about some factors related to health disparities and health equity. Factors such as having continuity of care, language and communication barriers, lack of diversity in the healthcare workforce, high rates of poverty, lack of insurance coverage, discrimination, and large distances from healthcare services have all added to the disparities that affect American Indian Alaska Native communities. These factors published in the United States Department of Health and Human Services has defined this as social determinants of health factors. So there are 5 categories of social determinants of health. So first one being economic stability, number 2, education, number 3, social community settings, number 4, health and healthcare, and lastly, neighborhood environment. Disparities in American Indian Alaska Native health will not improve just by focusing on numbers. Instead of improvement can be made through community health education and economic standings, and by creating healthier and engageful communities. So some progress has been made. Here's some data to support some progress within our healthcare system. So for Native Americans, 2 out of 3 with kidney failure will have diabetes. In 2017, the Indian Healthcare Service reported that it had decreased kidney failure from diabetes by 54% among American Indian Alaska Native between 1996 to 2013. Kidney failure from diabetes in American Indians was the highest of any race, but has now declined the fastest throughout Indian healthcare services strategies focused on population management approaches to diabetes care, as well as improvement in clinical services and care. So how do we overcome health disparities and health inequity? Adequate funding that supports evidence-based, outcome-based, and community-based approaches is essential. Quantifiable goals need to be set that focus explicitly on chronic illness reduction and associated measures needed to be defined and closely monitored. And lastly, a strong investment in public health and illness prevention is essential to turning the tide on severe chronic diseases impacting these populations. So now let's bring it back to the last year, the last 13 months related to COVID-19. The pandemic posed a grave health threat to Indigenous people. Indigenous communities already experienced poor health care at significantly higher rates of communicable and non-communicable diseases, lack of access to essential services, sanitation, and other key preventative measures, such as clean water, soap, and disinfectants. Today, the American Indian Alaska Native make up about 2% of the United States population, but are often left out of the national data analysis or marked as statistically insignificant. Indigenous people continue to be disproportionately impacted by COVID-19. According to CDC, American Indian Alaska Native are 3.5 times more likely to contract COVID-19 and 1.8 times more likely to die from the virus than white people. Among American Indian Alaska Native, mortality was higher among men than among women, and the disparity in mortality compared with non-Hispanic whites was highest among persons ages 20 to 49 years of age. According to the CDC, American Indian Alaska Native people are 5.3 times more likely than white people to be hospitalized due to COVID-19, the largest disparity of any racial or ethnic group. Here's a graphic here of, and this is recent data here of our agency-wide positivity rate due to COVID-19 or the SARS-CoV-2. So you can see this is all of our 12 jurisdictions in the United States here. So this is an aggregate or cumulative data set here. Notice 13 months ago, you can see it really spiked up, and then in the winter months, this past winter, it significantly increased. As of last week, we are at 3.2. So this is agency-wide. Now I'm going to bring it to Albuquerque here. So this is Albuquerque area here. More of a jagged kind of picture here. You can see it really start spiking up at the very early of the pandemic. Then in the winter months, you can see it also spiked up there. But right now, as of last week, we are at a 5.5% of COVID-19 test positivity 7-day average rate. And public health recommendations for vaccinated persons, and we do know that this is there's lots of data surrounding these measures here, and we all know them. And I'm not going to read some of this, but they are very familiar within our professional and personal lives here. So again, continuing to follow these public health recommendation is going to be of prime importance as we try to mitigate and be successful at moving forward and combating the pandemic. So let's now go into the technical side of the vaccines here. As we know, there are 3 types of vaccines that have been given EUA approval here. So we're going to talk about 2 of them here. So this is the messenger RNA COVID-19 vaccine. And why do we bring this technical aspects to the forefront? We have to understand the background, the foundation on how these vaccines have been stood up so that we're being able to deploy and effectively educate our consumers here. So this is related to the Pfizer vaccine and also to the Moderna vaccine here. So these are what we call messenger RNA. So just some facts about the messenger RNA COVID-19 vaccines. They cannot infect anyone, does not use the live viruses, does not affect or interact with our DNA. It never enters the nucleus of the DNA cell. We do know that it makes a harmless copy, and its strategy or its focal point is making adjustments to the spike protein so that it creates an immune response so that antibodies can be able to detect and identify the SARS-CoV-2 virus as it enters into our body there. So basically that's kind of how this particular messenger RNA was designed. We do know that there's lots of studies to support that this classification of vaccines has been studied rigorously for safety and effectiveness and has been the standard since the onset of deploying these vaccines. And this is a schematic or a cartoon of how the vaccines work here. Basically, it's formulated in a laboratory and it's injected into a recipient. And then as you can see on the right-hand side there, there's antibodies that are formulated so that when it detects the virus, it will develop an immune response so that it can fight off and ward off the infection. As I mentioned, there are two messenger RNA vaccines. This is the Pfizer vaccine. We do know it's an ultra cold frozen vaccine. It's a 2-dose series. The efficacy is 90% effective. In this particular early stages, American Indian Alaska Native volunteers were recruited to participate in their earlier studies of the Pfizer vaccine. We do know that this EUA approval is for 16 years and older. And right now, as of today, the ACIP, which I'll talk about in the coming slide here, has just recently, a few hours ago, approved 12 through 15 years of age cohorted vaccination age group. So we have still more work to vaccinate the next segment of our important patient population here. So again, there's more to come. I know there are more clinical studies that are happening with messenger RNAs for younger patient population as young as 6 years of age and to 11 years of age here. Going on to the Moderna vaccine, we do know this is a frozen vaccine. It's also a 2-dose series. Its efficacy is 95%, and it's earmarked for 18 years of age and older here. Again, these vaccines are proven safe and effective and are also not also 100% effective as well. So we do know that there are some breakthrough instances when individuals have been vaccinated, they were able to be susceptible to the virus to be infected. So again, these vaccines are safe and effective. They are not 100% to prevent the communicable disease to be infecting us here. So it's just that opportunity to continue to be vigilant with our public health orders. So now moving on to the next classification of vaccine. This is the Janssen Pharmaceutical Division of the Johnson & Johnson vaccine here. So it's not a messenger RNA, it's more of a non-replicating viral vector or adenovirus COVID-19 vaccine. It is formulated from a traditional approach, meaning the existing vaccines that we have are for our regular adult and pediatric patient. This is how the vaccine has been formulated. So it uses a harmless human cold virus to deliver the SARS-CoV-2 gene to the human immune system, which then learns to protect the body against COVID-19. The J&J vaccine is based on a virus genetic instructions for building the spike protein. But unlike the messenger RNA vaccine, which stores instructions in a single-stranded RNA, the J&J vaccine uses the double-stranded DNA to replicate the instructions as it builds and modifies the spike proteins here, as you can see in the cartoon to the right. Some facts about the J&J vaccine. It's a single-dose vaccine. It's stored in the freezer and refrigerated temperatures. Depending on the areas of protectivity, 66% has been proven to protect against the disease, 72% for severe diseases, 85% for preventing severe diseases. It's also been known to combat multiple virus variants, specifically the South African mutant or the strain that is circulating the globe here. So as we know, some good facts about the J&J vaccine. Back on April 13, the FDA and CDC put the vaccine on hold. Then 10 days later, on April 23rd, the same organization, CDC and FDA, recommended to resume the vaccine after a temporary pause. After reviewing the available data shows that the vaccine has been known and potential benefit outweighs its potential risk there. So there's lots of data to support this here. So any recipients that succumb to any of these symptoms should contact their local healthcare providers that include severe headaches, abdominal pain, leg pain, or shortness of breath within the first 3 weeks after receiving the JNJ vaccine. So now let's switch to variants. There's been lots of discussion and probably will be an ongoing conversation in the community, scientific community, and also public forum here about variants here. So let's break this down into bits and parts about what a variant is here. So we do know every any viruses that is known to human, the viruses is constantly changing. So new variants or mutants can occur at any time. And there's many catalysts that can predispose a virus to become a mutant here. The virus that causes the COVID-19 is a type of coronavirus or a large family of viruses. It's also known for the crown-like spike on their surfaces here. By analyzing throat and nose swabs from patients, researchers can detect new SARS-CoV-2 strains with mutations in the spike protein. Scientists are continuing to monitor the changes in these viruses, including on the surfaces of the viruses, specifically those spike proteins here. Genetic analysis of the viruses are helping scientists understand how changes to the virus might affect how it spreads and what happens to people who are infected with these variants. So let's dissect this particular slide here. So I want to have you focus in the lower right-hand corner there. There's a cartoon there. It's a circular SARS-CoV-2 cartoon there, and you can see those spike proteins there. Within the genome of the SARS-CoV cell there, you can see the wiggly lines there. So if you take that genome and you stretch it apart, you come up with what you see on the left-hand side there. So that's the SARS-CoV-2 genome going from left to right here. From the scientific community here, the part that is very concerning is going to be the brown section in that genome, which is the spike protein here. So if there's any modification, any changes to that spike protein, that will meaning some meaningful concerns as we try to mitigate this virus here. It may be an impact on the way how we combat the mitigation risk, and also looking at if the vaccines are going to be indeed preventative and helping them curtail the infection onto us. So these variances are rapidly emerging. So at this time, there's no evidence that these variants cause more severe illness or increased risk of death. That's what we know here, but the scientific community is continuing to monitor this here. We do know that these variants tend to spread faster. They're more transmissible. They're more infectious. So currently there's no evidence to suggest that the variants has an impact on the severity of the disease or the vaccine efficacy here. We do know that there are several dozen strains or variants of the COVID-19 that are circulating globally here, and there's just a few here. So the most common one that we've heard in the last 2 weeks is the Indian variant on the continent of India there. Also the one that has also been on the headline has also been the United Kingdom variant as well. So again, there's much more opportunity for us to continue to do surveillance lab testing to identify if these variants do or existing in our communities. So now let's go into some public health awareness here. So this is going to be on vaccine hesitancy here. So looking at the schematic or the cartoon in the lower right here, we're going to look at these in the next 3 slides here. So what is vaccine hesitancy here? It refers to delays in acceptance or refusal of vaccine despite of availability of vaccine services. It's vaccine hesitancy is complex and context specific, varying across time, place, and vaccines, is influenced by factors such as complacency, convenience, and confidence. Here are 4 studies that I want to share with you. The first one is the Pew Research Center. The second one is the Gallup US polls. The third is coming from the New York Times. The fourth is from a reputable journal called the Journal of Community Health here. But look at the statistics on that end. All of them kind of span from 20%, 30%, 40% here of vaccine hesitancy, from the lay community all the way to some medical health workers there that are reluctant in receiving the vaccine here. So I just want to know that this is a United States data here, that vaccine hesitancy is really alive and well in many parts of our country here. So I just wanted to just kind of share some background with you here so that we understand that this is something that we should be concerned about. There was a study in the US Gallup Poll in late March here. There was a question that was asked in the survey here. So the question here was proposed like this here. It says, what is the main reason that you would not agree to receive the COVID-19 vaccine if one was available to you now? So the majority of the respondents, they're wanting to wait to see if the vaccine was safe. Another section of the respondents here don't think health factors of COVID-19 would be serious. So you can kind of read through this here. You can see some of the different reasonings on why there was a reluctance or unwillingness to receive the vaccine here. Going on to the next slide here. This is a graphic here. Is the Americans' willingness to receive the COVID-19 vaccine, also another Gallup poll in this same study here. You can see a year ago, back in July of 2020, you can see there was a similar survey that was done here. You can see 65% wanted the vaccine if it was made available, and 35% said no. But as the weeks and months progress here, it kept, you can see it decrease, and then there's a slow, steady increase. As of late March here, we are 74% of Americans willing to receive the vaccine. So very interesting data here as the deployment of the vaccine has impacted the way how we view and see these vaccines' efficacy and safety. Now, I'm going to now just summarize the next few slides. I'm going to now go very centric here now. This is with the Albuquerque area healthcare system here. This is a geographic map here of where we're located here. And I want to go very specific now to these locations here. And we're going to talk about how our healthcare system has evolved to curtail some of the pandemics within each of our native communities here. So we are an Indian healthcare system. It's comprised of federal system, tribal healthcare systems, and urban healthcare systems. As a consortium, we are about 27 healthcare sites throughout the Rio Grande. We have one site to the north up in Denver, Colorado. That's our further northern facility that we provide administrative services and technical support. And then we have a system way down south in El Paso, Texas. It's a tribal community called Isleta del Sur. All of our healthcare systems are along the Rio Grande, and most of you probably are familiar with this here. So as a healthcare system, we have 27 healthcare sites that we're able to provide vaccines and how they've been able to execute the services and give injections to our constituents. Here's our dosing allocation as of Monday here. So this is data as of Monday. For those people that look at data, data is always evolving here. So I dated this on May 10th here. So this is the allocation as of May 10th here. So the top section is your prime dose. Your bottom section is your booster dose. As of to date here, this is the very last line there. Total all vaccine doses, prime and booster, just includes all of our 3 vaccines. We have a total prime and booster allocated and distributed and pushed out to our sites is 118,500. So that's the number of vaccines that we've been able to push out to our facilities that you saw in the previous slides here. So now I'm going to use this ACIP framework to discuss my upcoming next slide here. This is the CDC Advisory Committee on Immunization Practice, also known as ACIP or ACIP. So they looked at priority phase groups. So this was published back in late of 2020 in December here. They separated these priority phase groups into 4 main phases here. And you're going to see these same framework here as I present my next slide here. So we're probably all familiar with this here. Phase 1A, 1B, 1C, and the last part is phase 2 here. So we're going to share that next slide here. So going from left to right here, going from December when the vaccines were first deployed, going from left to right all the way to May 10th is how we are looking at benchmarking how we're able to understand how we're able to meet and achieve our population numbers here. So what I'm going to start from left to right here, I want to start from the bottom here. So it kind of makes sense here. So 27 sites, healthcare facilities have met your healthcare personnel and long-term care facility. So remember that we're using the ACIP framework to mark and march through these going from left to right here. The next priority phase group is your 75 years and older. 27 of our sites have met this target very easily. The next priority group, which is frontline essential staff, 27 of our healthcare facilities met this target successfully. Now we're going into the yellow zone here. So this is where our work is still, we're still working on these particular priority phase groups here. 24 sites have met 65 to 75 years of age here. There's still a few more sites still making their way through this particular cohort here. So you can see 72% we have met, and there's 28% we're still a work in progress here. Going on to the next priority group, which is 16 to 64 years of age with high risk medical condition here. 11 of our sites have met this target. So this means that 55% of our facilities have met this group. 45% of them have not. So you can see there's still some more work that is still being done in this group here. The next is the essential staff, not in the previous identified group. So 9 of our sites have met this target, or 90% have met it, and 10% are still in the works of achieving this target here. And lastly here, in the green here, 4 sites have met this target here. So 4 of our healthcare facilities have completed phase 2. So that means 24% have met this target, and majority of our sites are still aiming to meet phase 2 targeted patient population here. So this is the way how we've been able to focus our resources and efforts in doing data population management as we're going through these numbers. Again, it's not all about numbers, but we've been able to use these data to kind of put in our efforts on where the efforts may need to be. Going on to the next slide here, this is data management on Pfizer and Moderna administration rate here. This also includes the JNJ vaccine here as well. So 85% administration rate of our prime booster, and then for the booster doses is at 90% here. So we do measure this week to week here. As you can see, there's been a 1% change from the week before here. So we are doing some effort. Not as many as we used to back in February when we were giving volumes of doses into patients' arms here. It has leveled off, but we still are continuing to be promoting the vaccine in our patient population here. So let's now talk about adverse vaccine events, or basically adverse events that happen to vaccines here, to our patients here. So we categorize this into 4 groups here: local reactogenicity, systemic reactogenicity, adverse events of special interest, or serious events here. So this is the way how we've been able to categorize how things led itself to safety and effectiveness of our vaccines here. We use 3 monitoring systems depending on the nature of the event. We all know about the Variance system. It's a national system that we can all report to. Even patients can report into Variance. The next 2 is the National Pharmacy Therapeutics Committee's system, more for sentinel events, and also the ISTAR, which is our internal incident monitoring system that we're able to add data so that we can also extrapolate data and track any adverse vaccine events here. In summary here, most of the adverse vaccine events have been commonly side effects, meaning they're just your basic reactogenicity. 1/3 of them reported or medically attended health impact. And then there's a few cases of suspected cases of bowel palsy, and 2 instances of anaphylactic reaction. Again, this is the Indian healthcare system wide throughout the country. This is just not Albuquerque area. Our Albuquerque area data has also been in the national data as well. So some of the top 10 symptoms by frequency, and I'm sure you're all familiar with this here, that are related to any of the 3 vaccines that I just presented here: dizziness, paresthesia, headaches, fatigue, nausea, arthralgia, dyspnea, or shortness of breath, flushing, hyperhidrosis, and a rash. Okay, moving on to a very interesting slide that I want to share with you. I'm sure some of you may have already seen this here. Basically, it was on the cover of the New York Times on February 21st. It took the whole page here. And what I did is I just cut this in half. So look at it from top to bottom as a linear pictorial of what the New York Times shared here. Basically, what it is, it was identified on the front page, a wall of grief. And it began with 1 dot. Then it grew nearly 500,000. The graphic on Sunday's front page depicts the totality of COVID's devastation in the country. So each of those gradients are dots. Notice in the winter months here, the dark areas there, the more highly visible area, that was the winter months here. Obviously, as if these dots were continued here, you'll see a little improvements as the shades get lighter here as we're going into vaccination and getting our individuals vaccinated here. So anyway, very interesting. And again, this is identified as the wall of grief. So now the last few slides I want to share with you here. Let's now bring it more to the Native Americans here. So let's talk about why Native Americans are getting COVID-19 vaccines faster than any other segment throughout the country, maybe even the world, if that's an opportunity there. So IHS has administered over 1 million doses of COVID-19 vaccine as of date at the rate of about 18K per 100,000. That's higher than all but 5 United States, according to the Associated Press analysis of federal data. Native Americans are more willing than the general population to be vaccinated against the coronavirus, primarily out of responsibilities to their communities and preserve cultural ways. A survey of Native Americans across 46 states found that 75% of participants would be willing to receive a vaccine. Some prioritization that led when we began this back in December here. there was an incentive from community members to vaccinate native fluent speakers and traditional healers, were most of whom or elders were the earliest recipients of the vaccines. So these were some good data to represent as we began our journey to vaccinate back in the early months of, actually it was the latter part of December of last year here. Why are they also getting the vaccines faster here? Obviously, the system has a robust healthcare informatics database. We're able to do easily and carve out patient demographics, population management, as we're able to utilize the software system. The workforce is very flexible and resilient. Do more with less. I think that's the mantra of our agency. Leadership support and visibility, significant tribal leadership support, quick adoption of the coronavirus prevention measures. Community owns their healthcare system. I don't know if you knew this for the listeners on the call here. We have stakeholders, governing bodies that run their own healthcare systems. And I mentioned there's 27 healthcare facilities. They're all owned by the community themselves. So they dictate how services are going to be rendered, how fundings are going to be used, how services are going to be rendered there. So I just want to make sure that people understand that the community owns their healthcare system. We also did extensive tailored messaging and community cohesiveness. Creative education and outreach materials will also continue to be a useful tool in our artillery here. Confidence building efforts has also been a steadfast importance in building confidence as we're trying to mitigate hesitancy as well. So here's data from CDC here. Let's look at the bright yellow line here. That's the American Indian Alaskan Native profile there. So to the left here, it's individuals that has received at least one dose. To the right are individuals that have been fully vaccinated here. But look at the other racial, ethnic categories here. To your right there, you can see how they stand out in their getting the vaccines here. Kind of more data to show that our healthcare system was already primed to start to vaccinate our recipients as quickly and rapidly as possible. So in highlight here, I believe this was maybe my last slide here. So I want to give some highlight summaries here. Again, this is data as of late April here. So we had several questions here. So this was very thought-provoking and very interesting in how the data lend itself as we're continuing to review the data here. Again, this is data from the Albuquerque area Indian healthcare system here. So we wanted to know who participated in receiving the vaccine within the Indian healthcare system of the Albuquerque jurisdiction here. So we know that 75 unique federally recognized tribes were represented here. So very melting pot. That just kind of open our eyes that there's a lot of customers that utilize our healthcare systems, not only the 22 New Mexico tribes or the 2 Colorado tribes that we serve or the 1 Texas tribe we serve there, but 75 unique federally recognized tribes were represented in our recipient profile. 8 service units, and I want to clarify, sometimes individuals misterm service units. Service unit is more an administrative organizational code. So just kind of, I don't like to use the word service unit because it has different connotations and meanings to it. I like to refer to them as healthcare facilities here. So within the 8 service unit, there are 16 federal healthcare facilities that participated in the vaccine administration. 7 tribal healthcare facilities were also included. We also included our non-software host site, which is called the RPMS database. They include Denver, First Nations, Kiowa, and Alamo. So they were also included in the data here. Also with counties here, there were 31 unique counties in the Albuquerque area jurisdiction were represented in the receiving of the vaccine here. And the last bullet here, 260 unique zip codes in the Albuquerque area jurisdiction were also represented in the receiving of the vaccine here. So very, you can see how vast the vaccines have reached many parts and sectors of our healthcare system. And this was very interesting to look at here. Now, the point that I want to share with you, there's a cartoon or a graphic to the right here. You can kind of see how we're faring out. This is data as of last week here. You can see the total number of doses administered in the Albuquerque area jurisdiction. You can see how many were partially vaccinated, and you can see how many were fully vaccinated here. So you can see the total number of workforce that lend itself to for those shots to be administered into patients' arms here. You can see how much workload that it took with such a small, I want to say, workforce that we're able to do this here. So I'd like to now go into Q&As here. Again, thank you for the time and opportunity for me to share our experiences and lessons that we've learned as we deployed our vaccines to our very vulnerable patient population. As we embark into another segment of our patient population, which is the adolescents and pediatric patient population, is going to be our next prime focal as we start working in the coming weeks as we prepare our workforce to meet those goals and demands here. Again, thank you.
And thank you, Captain Darwin. That was wonderful. We do have one question already, and the question is, are there any restrictions or areas of concern with the vaccines for women who are pregnant or couples looking to get pregnant?
Oh, very good question. And I just want to make sure I'm getting some feedback. Can you hear me?
Yes, I think it's I think it's from my computer, so I'm just going to mute while you answer.
Okay, all right, very good, thank you. So very good question here. So for pregnant or breastfeeding women, these vaccines are proven to be safe and effective. If there are any recipients wishing to get the vaccine, I would recommend the recipient to contact your local nearest Indian healthcare system facility to schedule an appointment. Like I said, our pods or community vaccine events has lessened, but they're going to be ramping up as we're preparing for pediatric and adolescent. And those recipients can also be able to get their vaccine at those times as well. Hopefully that answers your question.
Great, and if anybody has any other questions, please do post them in the Q&A session app of the, in the Q&A section of the Whova app. I was taking notes here, and I maybe you mentioned it and I simply didn't catch it, but what is the timeline for the rollout, or do you have that for the pediatric and adolescent vaccine?
All right, very good question here. So as we learned on last Friday, FDA has approved EUA modification to include the new age cohort. So that was on Friday. So that's in the EUA approval. So the next focus this week here and over this past weekend, and they just concluded early today, is the ACIP. That's the main organization that the consensus body voted overwhelmingly to endorse the FDA's approval for this age cohort. So now, so we have that go-ahead green light now. So now our agency will be talking later today and tomorrow on how we're going to put some guidance to our facilities throughout the country. Obviously, the same information will be shared with our 27 healthcare facilities in our Albuquerque jurisdiction on how we're going to be able to meet the demand here. In reference to the Pfizer BioNTech vaccine, We are ready. We've sequestered enough doses to meet the population. So we're going to be able to deploy them through our hub and spoke model redistribution of our vaccine in the coming days here. So we're looking forward to getting the vaccine, pushing them out so that they can start to do some local coordination and logistics and scheduling clinics, recalling pediatric patients, and obviously the consent to get that approved through their parents or guardians so that they can be able to be vaccinated. So some more work that needs to be done at the administrative level, but more than that, we should be able, often going to get those injections to our pediatrics and adolescents' arms.
Excellent, excellent. We have another question that's come in, and thank you for your answer. The next question is your thoughts on natural immunity versus vaccine immunity and daily vitamins.
Very good question here. Obviously, any good immunity, obviously hydration, eating well, being holistic with the way how we treat our bodies is also very important. Those are going to be added benefits. Also, there's no clinical studies to support natural immunity. I'm sure there's going to be more studies that will be unraveling in the coming months to years in reference to the coronavirus. So as we get to know more data about natural immunity, we should have more data to support how to answer that response here. But there's been extensive study related to vaccines on its safety and efficacy. And we do have, those statistics to know that these vaccines are proven to be effective and safe. They're not 100% effective, but they're near perfect. So I just want to add that to the conversation.
Okay, it looks like that is all for our questions, unless we have, we have a reply. Let me see. Oh, very good. Yes, that answered the question. So very good. So I believe that we have finished our Q&A then, unless anybody has another question. I'll go ahead and give everybody the information on how to find the materials. And then if there is any last minute question, please post that again in the session Q&A on the Whova app. You can find that on the left side of the menu of the Whova app. And then if we can go to the next slide, we'll just remind you that any materials today will be provided in the Whova app. You can also find those on the website at nmhealthequity.org. And you can complete the evaluation there by clicking Rate within this session. For any assistance, please contact us at the info@constellationnm.com. And then in closing, I'm not seeing any more questions coming in. So Captain Darwin, thank you so much for being here today and joining us with this invaluable information and your expertise. We truly appreciate everything you're doing and all the efforts for our communities and helping to make New Mexico a better and safer place to live. So thank you. And thank you to all of our attendees as well for being here. And remember to check the dashboard on the Whova app for information about upcoming sessions and for accessing any sessions you may have missed. And then, of course, including today's session coming up here. What is the session? Next session is the hyperactivation. Oh, is hyperactivation your new normal? By Kristen Carmichael. So that's still coming today. So thank you so much and have a lovely afternoon.